Welcome to Derm Drop, your TLDR in dermatology. I'm David Sider, bringing you quick picks from the dermatology literature and other sources in the dermatology community that are interesting and impactful. We're going to start this episode with the question of whether to step up or step down, and evidence that from both an efficacy and cost perspective, traditional treatment escalation may be backwards, at least in younger psoriasis patients, according to a study published in the February 23, 2025 issue of the International Journal of Dermatology by researchers at Brussels University Hospital and the School of Public Health at the Free University of Brussels in Belgium. Whether due to training, lack of comfort with newer therapeutics, or restrictive reimbursement criteria, we typically start with topicals and step through phototherapy and older systemics before going to biologics. While it may be no surprise that more patients, especially younger patients, median age 36.9, on biologics achieved PASI 75 in the short term, less than 35 weeks, compared to topicals, phototherapy, and conventional systemic therapy, in the long run, greater than 40 weeks, the differences in response rates narrowed. But in the meantime, ineffective and even slowly effective treatments drive up costs secondary to treatment non-adherence, increased morbidity, frequent changes in therapy, increased office visits, whether for evaluation and management or treatments with narrowband UVB or intralesional corticosteroid injections, and absenteeism from work when accessing healthcare or due to debilitating or embarrassing disease flares that keep patients at home. Furthermore, one of the predictors of super responders to biologics is not having received systemic therapy prior to biologic initiation, giving us yet another reason to skip the DMARDs. And now, biosimilars are driving down the cost of biologic therapy, and extended dosing schedules are emerging as viable maintenance strategies. So, a step up approach may not be the most cost effective approach, especially in younger patients for whom disease progression may be interrupted. Similar findings in Crohn's disease, multiple sclerosis, rheumatoid arthritis, and psoriatic arthritis suggest that early biologic intervention provides better disease control, improved clinical outcomes, and higher remission rates across many disease states. Thanks to Yasmina Baylock, Celine Dandoy, Fabienne Williart, Claire Debouchet, Hassan Najimi, Benhadou Farida, Veronique Delmarmol, and Jonathan M.L. White for crunching the numbers from the Belgian Psoriasis Registry. Thanks also to Marie Boslet for bringing this study to my attention in Dermatology Times recently. So, hit it and quit it, or at least hit it and taper it if you can. Considering the long-term sequelae of psoriasis, you may be saving lives and money by intervening with biologic therapy earlier. Our next quick pick starts with the question, do you have trust issues when you prescribe clobetasol for lichen sclerosus? Do you lie awake at night wondering if the patient will keep their high-potency topical steroid confined to the affected area or taper it as control is achieved? I know I do, and if you're like me, consider prescribing hydroxychloroquine instead. Almost 85% of patients with anogenital lichen sclerosus in a retrospective study conducted at the Mayo Clinic in Rochester, Minnesota between 2018 and 2023 and published July 19, 2024 in the International Journal of Dermatology demonstrated a positive clinical response to hydroxychloroquine with low incidence of adverse effects. In fact, adverse effects were predominantly mild and observed in only 14.3% of patients. So, you can definitely sleep easy with this one. Patients got to be patient though, as the median time to initial response was 4 months. And only 50% of those with extragenital lichen sclerosus responded. So, hydroxychloroquine may not be the right choice for them. Thanks to Christibella O. Akpala, Barak Tekin, Rochelle R. Torgerson, David Wetter and Jiang Huang Nguyen for keeping the Et atrophicus out of lichen sclerosus. However, with just 70 patients in this single center retrospective, anybody out there want to do a larger scale prospective study? That would be great. Our next quick pick starts with the question, are you sure it's eczema and not clinically amyopathic dermatomyositis? A retrospective cohort study conducted at Johns Hopkins Myositis Center and published February 26, 2025 in JAMA Dermatology found that clinically amyopathic dermatomyositis is commonly misdiagnosed as inflammatory skin disease. Cutaneous lupus erythematosus, 67%, and eczema, 29%, were the most common misdiagnoses preceding confirmed dermatomyositis. And 72% of those misdiagnoses were made by dermatology providers, believe it or not. The clinically amyopathic dermatomyositis cohort had higher misdiagnosis rates than the myopathic dermatomyositis cohort, that was 44% versus 21%, and longer median delays to correct diagnosis, 236 versus 114 days. And the amyopathic phenotype, comprises 20% of dermatomyositis presentations. Those delays resulted in higher one-year hospitalization rates, 54% versus 33%, and higher one-year interstitial lung disease incidence rate, 71% versus 43%, with lower median diffusing capacity for carbon monoxide, commonly referred to as DLCO, at interstitial lung disease diagnosis compared to those without a prior misdiagnosis. So these weren't harmless errors. Luckily, cancer outcomes were comparable between the groups, but the highest incidence of dermatomyositis-associated malignant neoplasm occurs in the first 3 years after symptom onset, so delayed diagnosis may result in reduced surveillance and vigilance when malignancy risk is highest. The researchers note that dermatomyositis has diverse clinical presentations and cutaneous findings, and that eczema emerged as a notable mimic due to similar distribution and morphologic features. So if your patient's eczema includes periorbital erythema, commonly referred to as heliotrope, poikiloderma on the shoulders, the shawl sign, scaly plaques over the lateral hip, which is the holster sign, flat-topped papules on the dorsal metacarpophalangeal joints, or Gotron papules, and or capillary loops at the proximal nail fold without proximal muscle weakness, they may have clinically amyopathic dermatomyositis. Thanks to authors Aaron Bao, Saloni Patel, Christopher McCauley, William Kelly, Jemima Albayeda, Brittany Adler, Julie Paik, Lisa Christopher Stein, Eleni Tiniaku, Jun Kang, for reminding us to slow down and get it right the first time. And finally, our last quick pick of this episode starts with the question, would you prescribe upadacitinib in a tobacco smoker? Well, the evidence suggests you can, as scary as that sounds, particularly when the patient's only cardiovascular risk factor is smoking. A retrospective multicenter study conducted by Francesco Leo, Michela Ortoncelli, Ruggero Cassio Ingurgio et al. Across 12 dermatology departments in Italy and published in the American Journal of Clinical Dermatology, looked at 375 patients with atopic dermatitis treated with upadacitinib. Almost 37% of the study participants were tobacco smokers with an average duration of over 15 years and a mean daily consumption of over 9 cigarettes. That's 8.5 pack years. And guess what? No significant safety differences were found between the smokers and the non-smokers. A sub-analysis of those on the higher 30 milligram per per day dose, which was 43% of the smokers, did not find a difference either. In fact, the two thromboembolic events that occurred during the 2-year study period, 52.6 weeks median follow-up, were in patients who did not smoke. This study reaffirms other clinical trial and real-world data regarding the risk of venous thromboembolic events in AD patients on JAK inhibitors, and the authors point to a recent systematic review and meta-analysis that reported no significant safety differences between atopic dermatitis patients receiving dupilumab or placebo and those on JAK inhibition. Remember, atopic dermatitis patients appear to have lower cardiovascular and thromboembolic risk than those with rheumatoid arthritis at baseline. And the oral surveillance trial did not show that tofacitinib, which inhibits JAK3 in addition to upadacitinib's JAK1 inhibition, increased RA patients' risk of cardiovascular/thromboembolic events from baseline, only that it may not be as cardioprotective as adalimumab in this population. So would I prescribe upadacitinib to a smoker? Well, if it was the right choice for the patient, I would. Hopefully, this gives you a little bit more comfort in considering this great drug for those patients who need it. And that's it for this episode of Derm Drop. If you would like links to the articles and other sources, go visit my LinkedIn page under David Seiter. That's Seiter. And thanks for tuning in to Derm Drop.